which is not a good thing. What about the lateral canal? Here you will see how we test the lateral canal or the McClure maneuver. We ask the patient to flex his head 30 degrees and we turn the head to the right, then to the left. This is the first part of the test. We wait a few seconds, then we turn to the opposite side. So what happens? You have here two options. The first one is what we call the canalolithias. So when the otoconias are floating in the long arm of the lateral canal, you will be having nystagmus on both sides. Make no mistake, the lateral canal, you will have nystagmus on both sides that you are testing. In the canalolithias, you will have a horizontal geotropic nystagmus on both sides. So the nystagmus will go towards the ground on both sides and it is horizontal. How do we know the affected ear? The affected ear is where the nystagmus is stronger. So the stronger side is the affected side in the canalolithiasis of the lateral canal. It happens in around 8 to 10% of the cases. Why? Just to go back a little bit to the anatomy. Our semicircular canals are coupled together. You have the anterior on one side and the posterior on another one. So this is the same for both ears, but the lateral canals are coupled together. So we cannot test one canal alone for the lateral canal. Okay, this is why we have the nystagmus on both sides. What are the characteristics? Usually the latency is shorter than the one of the posterior canal, and the duration of the nystagmus is longer. How do we treat it? The canalolithias lateral canal. We ask the patient to lay on his back. We turn him towards the normal ear. Okay, the rotation should be towards the normal ear. He needs to turn 270 degrees. This is what we call the barbecue maneuver. It's like we're doing a barbecue for the chicken. And then we ask the patient to sit. This is a very effective repositioning maneuver for the lateral canal when it is a canalolithiasis lateral canal. I know it's a little bit complicated, but in practice, you will see when you are going to practice it, it's going to get easier. What about the cupulolithias of the lateral canal? Its characteristics are completely different. You will have what we call an apogeotropic nystagmus. So the nystagmus will be beating away from the floor. It's not over the floor, it's not geotropic, it's apogeotropic nystagmus. And it is still horizontal. How do we know the affected ear? Here it is just the opposite. The weaker side of the nystagmus is the affected ear. So it is the opposite of the canalolithias of the lateral canal. So this is what you will see basically. This is a patient that has a lateral canal but cupulolithiasis. If you start on the left of the screen, you will see that the nystagmus is very slow. When you look at the right screen, you can see the nystagmus is much stronger and much clearer. So the affected side in this patient is the left side, it's not the right side. Okay, so this is important to keep in mind. I know it's a little bit complicated, but yet again, with practice, it's become easier. So how do we treat the cupulolithiasis of the lateral canal? We do what we call a Guffoni's maneuver. Guffoni's maneuver, we ask the patient to sit, we lay him directly and in a very fast manner to the affected side. We wait 2 to 3 minutes. We bend his neck forward and upward, and we wait 2 to 3 minutes. Then we ask him to sit again. Usually, two things will happen when you do that. Either you will return the otoconias directly to the utricle and you're okay, or you can convert it to a canalolithias, a classical canalolithias, so we can do the barbecue maneuver that we discussed earlier on. So this is how we treat the lateral canal. I know it's a little bit tougher than the posterior canal, than we do the regular airplay, and it's okay, but this one, it's also very treatable. Other options for the lateral canal, we can use Vanucci. We need to ask the patient to sleep on the unaffected side for 12 hours, but I don't think it's very feasible. Branderoft, again, not so. Head shaking, not so. Do we need to do further testing for every Bppv patient? No, we should not ask for imaging for irregular Bppv. There are very specific guidelines when do we ask for imaging. So if the patient is not responding well, when we say not responding well, it means 3 attempts to treat the Bppv, let's say with Epley's maneuver 3 times, and still you still have like a regular Bppv finding, you need to ask for an MRI. Why? We can have intractable Bppv. What is intractable Bppv? It means a Bppv that is resistant to everything. Why it can happen? Because sometimes we have morphological abnormalities of the inner ear, like you can see in the photo up on the right. You have stenosis of the canal, so the otoconias will get stuck inside and you will not be able to do a good repositioning maneuver. There are also other causes. So is it? No, unfortunately, no. We have some special cases. I'm gonna go through them a little bit quickly, but they are important. We have what we call secondary Bppv and non-benign positional vertigo. We start with the secondary Bppv. It is a Bppv, but secondary to another disease. Usually you have several diseases that can cause that. Among them is Meniere's disease. 70% of Meniere's disease patients will experience Bppv during the attacks or between the attacks, because of course the inner ear is compromised by the high drops, so we'll have easier or higher chances of moving otoconias debris into the lateral posterior canal. Vestibular neuritis, 10% or 12, up to 20% of the patients who have vestibular neuritis will develop Bppv in the next coming 2 weeks. So it is justified to do a Dixwell-Pike maneuver for such patients 2 weeks, of course, after the initial crisis. Don't do the Dixwell-Pike maneuver during the acute phase, otherwise the patient will vomit on you. It's not worth it. So it is important also to keep it in mind. Migraine, sudden hearing loss are also associated with a higher rate of Bppv, probably because of the vascular compromise secondary to migraine. It will make the utricle a more fragile place and it will release otoconias more easily. What are the, let's say, the characteristic of such secondary Bppv? You will have a much higher incidence of bilateral Bppv compared to an idiopathic Bppv. And in Meniere's disease, the most affected canal is the lateral canal. And like we said earlier on, a couple of weeks after vestibular neuritis, you need to do a Dixwell-Pike and check for a secondary Bppv. What's the problem with secondary Bppv? Probably you will be needing a higher number of canalist repositioning maneuvers. So it is a more resistant disease. The duration is longer. You have multiple canals involved and sometimes a higher rate of subjective Bppv. Just to remind you, is when you have vertigo but without nystagmus. What about non-benign positional vertigo? Like we said, not all positional vertigo are benign. You should keep at the back of your mind the differential diagnoses which are serious, that will affect the central nervous system, like stroke, multiple sclerosis, or tumor. Ideally, if we can afford to do an MRI for all patients, we will not be missing any, but it's not feasible. So when should we suspect this non-benign positional vertigo? First, obviously, when you have any other symptom or sign of neurological disorder, this is very obvious, no need to discuss it further. Second, when you have nystagmus without dizziness, so it is the opposite of subjective dizziness. When you have this, you need to ask for an MRI. When you have an atypical nystagmus direction, we mean by that a vertical downbeating nystagmus. It might be normal in migraine patients, but don't take it for granted if a patient who is migrainous and he has a vertical downbeating nystagmus that it is normal. Go ask for an MRI. The second thing, when you have a direction changing nystagmus, especially if this direction change without doing a repositioning maneuver. because we said earlier on, when we do the repositioning maneuver, we might convert the Bppv from a posterior one to a lateral one. So we will have a different type of nystagmus. Instead of being a torsional geotropic nystagmus, it will become a horizontal nystagmus. So if you have a direction changing nystagmus without repositioning maneuver, go ask for an MRI. When you have a poor response to therapeutic maneuver or frequent recurrences, sometimes tumor might manifest as such. So go ask for an MRI when you ever have such recurrences. Any place for surgery? Well, in fact, in intractable Bppv, there is a place, a very narrow place. Why we are so reluctant on doing surgery for Bppv? In fact, you have two types. We have the singular neurectomy, and we have the posterior semicircular canal plugging. In both techniques, you have a very high risk of losing the hearing. So unless you have an extremely buzzard patient, don't go for surgery and try to do the repositioning maneuver when applicable. As a conclusion, although Bppv is quite common, it is, as you can see, quite challenging. But with little patience, a good diagnosis, and a good treatment, it will be fulfilling for you and for the patient. So you need to accurately identify the diseased canal. You need to accurately use the repositioning maneuver. Medical treatment is usually used as an adjunct. It's not a main treatment. Thank you for your attention. Do you have
First of all, I want to thank
question?
you. I want to thank
yes,
you, Dr.
Doctor, I have question, please.
Yeah, just a second.
Yeah.
I just want to thank you, Dr. Fata. And if you mind if we type the question, Dr. Mustafa, if possible? So this way everyone can see it and keep everyone mute. Thank you. I apologize.
Okay.
You can see the question,
Yes.
Doctor, in the chat area.
No, frankly,
In the chat? Okay.
I'm trying to...
Okay, just a second. We'll see if we have new messages.
Sorry, but I cannot see it. Where should
No
I
problem.
go?
I'll tell you. Do treatment pattern change with different Bppv? Yes, I think.
Yes, of course, because it differs which type of canal is involved, and you need to treat it correctly. So you have the Eppler's maneuver for the posterior canal, Guffoni's maneuver for the lateral canal, and the barbecue maneuver for the lateral canal. Barbecue, when you have a canalolithiasis of the lateral canal, and Guffoni's maneuver when you have cupulolithiasis of the lateral canal. So those are the three main maneuvers that you need to learn.
Okay. I'm going to see if we have another question. Till now, we don't. But I want to ask you personally, plenty of companies are advertising their, if you want, their chairs. I'm not going to say more than that, regarding repositioning. I personally have I will only use it in cases where I think performing the maneuver myself is hard. What's your opinion regarding this?
As you've noticed in the presentation, I put contraindication for the Dix-Hall-Pike maneuver. When you have a very obese patient, when you have severe neck problem, when you have severe stenosis of the carotid artery, those are the ideal patients for the TRV chairs. You know, those patients cannot do a regular Dix-Hall-Pike, cannot do a regular Eppler. You cannot turn them. Those are the very specific patients that that need to use the chair. Other than that, frankly, I don't see it's
perfect. Me too. Okay, so we have another question. What should be frequency of maneuver, and should it be followed up later?
Sorry, excuse me, I did not hear. Can you repeat, please?
What should be the frequency of maneuver, and should it be followed up later?
Okay, usually in 95% of the cases, if we